Good evening, everyone. So today I welcome Dr. Balaji Chinnasami sir, our patron and professor of pediatrics from SRM Medical College to conduct the clinical case discussion on cerebral palsy. I also welcome our presenter for today, Dr. Prashant, final year from MMC, who is going to present the case today. I welcome both. So sir, you can continue, sir. Thank you.
Okay, good evening, Paragu. Good evening. Thanks for giving this opportunity. And good evening, Prashant. Good evening. Some echo is coming, Pa. YouTube, I think it's on. Hello? Okay. Okay. So, Prashant, shall we start?
Yes, sir.
So before going, the voice is coming. Raghu, can you check the voice? Hello?
Sir, there is no issues from here, sir.
Well, I'm hearing an echo. YouTube, I think we should off the YouTube link, like the page.
Yes, sir, it's off. I guess in your laptop, sir.
My laptop, huh?
Yes,
Okay.
sir.
Wait, because I've kept it off only.
Now it's clear, sir.
Okay.
Yes, sir.
Okay. Okay, Prashant.
Yes, sir.
Before going, I would say that. So we will start with it. If you have opened any YouTube page, Prashant?
No, sir.
No. Okay. Just I'm
connected over Zoom, sir.
Zoom alone is there, no? Okay.
Yes, sir.
Okay. Okay. So before going on, I will just say that when is college going to be open, Prashant?
It's a question that none of us know for sure, sir.
Probably exams.
Probably the colleges might open on November 16, from what we know as now.
And exams might be around
February or March, sir.
February or March. Okay. So what I have understood that mostly you might be not given real cases. Most of the time you will not be given real cases. So don't feel that this is a futile exercise, whoever is listening. I think most often you will be given paper cases only. So there will be case scenario based discussion. Your ability to answer the questions asked by the examiner rather than the examination skills might determine whether we cross the line or not. So I feel my prediction is that only, because you should not get COVID from patients, and you should not expose the patient to COVID, and all those safety norms will be there. And MCA has given guidelines that simulated case scenarios, standardized patients, all those can be used rather than original patients. So mostly this exercise is what is going to help you in clearing your exams. Okay. So with that keeping in mind, I have planned, Raghu, can you show the final slide actually? So I have planned a series of cases. So somewhere around 10 to 15 cases, all will be related to your exam, which we can revise. I hope December will be the right time, I think. So if you have it around Jan or February, so all students who are interested, you can just WhatsApp me. My number is 944-5482-710. From there we can go on. It might be just a nominal fees we are planning. We are 4 more pediatricians are there. We are combined together. We will do the case scenarios, because I feel that case scenarios is how you are going to be tested upon. Okay, what do you feel, Prashant? I think
Yes, sir,
this
definitely.
is the way to go. Our examination skills may be tested less. The interpretative skills, the way we answer the questions, and you will be having a uniform pattern in the cases. So you will not be given difficult. There will be scenarios which you have to answer. Okay.
Yes, sir.
Okay. So we will move on to your case scenario. Okay. Go back, Prashant.
Raghu, can you share the slides?
So before moving on to the history, this is a case of cerebral palsy. I try to finish within 1 hour. We will try to, so that students can revise it back. I don't want to keep it lengthy. We will try our best. Before going to, we should understand what cerebral palsy is. Prashant, can you say what is cerebral palsy?
It's a static disease process involving the bodily movements and multiple physical systems of the body due to an antenatal insult, most possibly to the brain and the neuronal tissue.
Okay, good. So one is static. You said static. So it's not going to be progressive. So we have to see whether our case scenario is progressive or static in the issue. And then there is an insult in the growing brain. So we have to try to find out an insult in the growing brain, and which domain is predominantly involved in cerebral palsy.
The motor domain, sir.
Motor domain. So we have to prove all these in this history taking. So that's how our history and examination should be, trying to find out static encephalopathy. It should not be progressive, and see whether the motor system is involved, and at least predominantly involved, and see for the insult in the history. You have to find out the insult, why it has occurred. So that's the most important thing in the history. Okay, you can start, and I can give you examples. Okay, suppose you have a child who is walking well, going to school well, um, not going to school well, poor scholastic performance, not able to speak very well, doesn't have a good eye to eye contact. For a 4-year-old child, not having good eye to eye contact, schooling, scholastic behavior is poor, but able to play very well. Will you call that as cerebral palsy? That's the question, Prashant.
Uh, yes, sir, because it depends on multiple domains, multiple developmental domains. So we will
Hmm.
have to calculate the developmental quotient and look
Okay,
up if there
okay,
was a insult
okay.
which
So
we can trace to.
another scenario where the child is going to school well, reading well, performing well, all that the child is having a bit of limping, just a bit of limping with antenatal history. Some, when you go back, there might be there. So will you call that a cerebral palsy?
Uh,
Otherwise, fine.
Not
Otherwise, fine.
merely with limping, sir.
Hmm?
Not
Just
merely with limping.
okay, okay. So that's what I wanted to say, that based on the definition, the motor system should be involved. The other domains may be normal. The motor system should be involved. The other domains may be normal. So the limping child might, the motor system is involved, but otherwise the intelligence is normal. The child is going to school very well. So that all can be normal. So you can have a CP like that, but you cannot have a CP where poor eye to eye contact, poor language, but otherwise the child is moving around well. So that should be in the other domain. It could be autistic spectrum. So that part you should understand. So as you go, we will do that. Okay, you can start presenting. Okay.
Raghu, can you share the slides?
It's visible.
Good evening. This is Prashant. So my case is that of a 10-month-old male child, Master Mahesh from Ambattur, firstborn child of non-consanguineous marriage, brought by his mother, who is able to provide fairly reliable information. The child has complaints of history of stiffness of all the four limbs, which was noted since birth, and history that the child hasn't attained age-appropriate milestones.
Okay. Next.
Shall we continue, sir?
Okay. So we discussed the definition. So initial part, as you say, is the demographic details. So we are going to ask about the whether male child, what is the age. So here it is a 10-month-old child. Most important history which you have asked is the consanguinity. In the demographic history, what is most important is the history of consanguinity. A lot of inherited metabolic disorders are there which can occur because of the consanguinity. Okay. And with regards to the, we should have the mother's own words. So how about not attained age appropriate milestones? How can you use mother's own words? It should be presenting complaint, no? So how can we say, the mother might not say that milestones are delayed. So how will the complaint will be? Prashant, you are not audible.
Sorry, sir. Yeah. The
Mother's
mother
own
might,
words.
yes, sir. The mother might explain the milestones and say that the child has not attained them. About social smile and how the child has a stranger anxiety at 7 months. So when the mother believes that these stages have not been crossed by the baby,
So
the mother might
eat,
complain of the
not
same.
able to sit, not able to. So that's how we say, no, not able to sit,
Stand
not
with
able to
support.
walk. So how
Yes,
will
sir.
be the duration which you will say? So the presenting complaint is stiffness of all four limbs. Then not able to sit. What will be the duration? Now the child is 10 months, not able to sit. What will be the duration? Not able to
At
crawl.
around eight months, the child will be able to sit with support, sir. At the
Okay.
9th month, without support,
Okay. So how will be the
the
duration you
child
will
can
say?
sit. So
So
around
not able to
it will
sit.
be, so 3 months beyond the expected. 3 months
Okay.
beyond the expected
Okay,
milestone,
okay.
sir.
So we don't expect the baby to sit right from the birth, no? So
Yes,
I
sir.
prefer, like, we can say not able to sit till date. Till date, the baby is not able to sit.
Yes, sir.
And regarding words, the baby is not able to say bisyllables, monosyllables, not able to speak bisyllables or monosyllables till date. So that's how
Yes,
we
sir.
can say the mother's own words. Okay. Okay, ma. We can go to the next slide.
History of presenting illness. History of stiffness of all the four limbs noted since birth, which is progressively increasing in nature. History of fisting of both upper limbs. History of scissoring of both lower limbs. History of difficulty in putting the diapers and trousers. History of turning head to one side. Next slide.
Okay. Okay.
Yes.
So progressively increasing, you're saying, no? Progressively increasing. So
Yes, sir.
what do you understand? We said it should be static. It should not increase. So do you think that it is something which is worsening, or how do you want to say?
So maybe that the mother must have noticed about the stiffness at a later point of time, or could have felt it was normal initially, sir. So the mother could have felt that it was stiff at a later point of time, and hence felt it was probably progressive.
Okay. And stiffness alone, we cannot say that it is a degenerative disorder. You have to look into other milestones. Okay. And
Yes,
this increasing maybe because we have not given proper therapy. So the spasticity or stiffness can worsen. So based on that, we cannot say it is as neurodegenerative. Okay. And what does this fisting of both upper limb suggest? Fisting of both upper limbs.
uh, sir, there is a palmar grasp that the child attains, and uh, like uh, the child goes on to clasp objects at a later point of time when the child develops. But this child has his fist closed like a newborn neonate.
Okay.
So this shows that
Usually it disappears by. Usually it disappears by.
uh, around 3 months, sir.
Okay. So usually it should disappear by around 2 to 3 months. So if it is it should not persist. So if it persists, what does it suggest?
Suggests that the child has not crossed that developmental age, sir, and the
Okay. So
milestone.
it's probably an early marker of cerebral palsy. So fisting of both upper limb beyond 2 months of age is an early marker for cerebral palsy. Okay, so can you suggest some other such soft markers, early markers for cerebral palsy? Can you suggest such?
Um, Sir, in case the cranial nerves are affected, then the child may not respond to sounds. The
Okay,
child may not be able to speak or make sounds. Cooing or vocalizing might not be there.
okay.
Uh, and uh, and stiffness by itself, sir. Around, say,
Uh,
if it's a 6-month-old child, the stiffness might be felt and seen. There might be seizures accompanying. So these could be markers, sir.
but they don't actually we have some early markers of cerebral palsy. One you said is the stiffness. Okay, so excessive stiffness or excessive floppiness is an early marker. So the baby is born, the baby is coming to you in 3 months of time or 4 months of time, you may not be able to see everything. So these early markers will be there. So one is the floppiness or spasticity, and asymmetry of the movements. So you can have one side less movement and the other side, and paucity of movements. You can have the baby not moving much. So paucity of movements. Then delayed development, you have documented it. So delayed development will be an early marker of cerebral palsy. Hand preference. What do you understand by hand preference? Hand preference.
Sir, around 2 to 3 years of age, the hand preference arises, sir.
Okay.
Maybe a left-handed child or a right-handed child.
Okay.
So when this is not attained, like we can
If
call
it
it,
comes early, if it comes early, then it's
it's a
early
marker of
hand
cerebral.
preference is an early marker of CP, which means
Yes,
that
sir.
the other side is weak. So that's why the child is becoming handedness, right-handedness or
Yes, sir.
left-handedness. Okay. So hand preferences by 1 year of age. Tiptoe walking. If the baby is walking on the tiptoes,
Yes, sir.
and commando crawl. What is commando crawl? The baby walks with hands, with legs dragging. In
Yes, sir.
diplegia, you get no. So the commando crawl. All these are subtle signs of CP. So you have a developmental delay. Keep your hands clenched. Early hand preference. The baby is excessively floppy or spastic. The baby is having asymmetry of the movements, and the baby is having tiptoe walking, and the commando crawling. So all these are early markers of cerebral palsy. Okay, and delayed development, simple goal is the baby is not sitting by 8 months and not walking by 1.5 years. We call that as delay in the motor development. Okay. Okay, you can move on. And one more is scissoring of both lower limbs. You have said. What does this scissoring mean? Scissoring.
Sir, it's a scissoring gait that we expect, sir. Like the child is not able to go in a linear fashion, and that is a rotated movement, sir.
Okay, so that is there is a spasm or increased tone of the adductors. So adductors spasm, you have the scissoring. Very common in which type of thing? The diplegic type. You have the
Diplegia.
scissoring. Okay, and that's why there is difficulty in putting the diapers and the trousers. So whenever you ask any point, you need to understand why we are asking this. Okay, and
Yes, sir.
okay, move on. And and before going to the complications, I just wanted to ask, here we have stiffness as a presenting complaint and not attained the milestones. There is a delay in the milestones. I think elaborating the developmental history, you can say that since there is a developmental delay, I would like to elaborate the developmental history here itself, sir, before going on to the next part. Okay, I think
Yes,
that
sir.
you can elaborate. Raghu, can you move on to the developmental history? From there, we can go on, because that only defines the cerebral palsy, the developmental delay, where we need to show a predominance in the motor domain. No, so it's and that is the presenting complaint. They have come with
Yes,
that
sir.
presenting complaint. So let us elaborate that. Okay, okay, ma. Okay.
Developmental developmental history, gross motor, neck holding attained. Like the last milestone that the child has attained has been highlighted.
Okay.
So neck holding has been attained. Fine motor, the bidextrous reach is seen. Social and adaptive milestone, social smile has been attained. Language milestone, the child coos. Vision and hearing, vision fairly normal, and hearing does not respond to calls.
Okay. Okay. So what do you feel?
That the child has not attained the respective milestones which it has to at 10 months of age in all the four domains, sir.
Okay.
Like, yes, sir.
Mm. Okay, so we feel that cerebral palsy important is developmental delay. So important component is developmental delay. So that needs to be elaborated. So how are you going to present developmental history? So ideally in exams we have an
Uh,
expectation. No, how do you?
a list of all the milestones that the child has attained at the respective age, sir.
Okay. So for each domain, you are going to elaborate the developmental milestone. So for this child, how about neck holding? Neck holding.
Neck holding has been attained, sir. Around 2 to 3 months of age.
So when
Uh,
was it attained? When was it attained? So that
uh,
is more important, illa?
yes, sir.
So when was it attained? And now what is the age? Now the baby is 11 months.
10 months, sir.
10 months. So when was it attained? So we have to ask that. For
Yes, sir.
each milestones, start writing up to 10 months. So the baby's chronological age, to start writing one by one the milestones. So neck
Yes, sir.
holding, rollover, sitting with support, sitting without support, and when was it attained. So if the baby has not attained those things, no problem. You stop with it. So here the baby is not even attained the rollover. The baby has.
Yes, sir. The baby has not attained rollover. The last milestone is the neck holding that the baby has attained.
Okay. So now, what is the development quotient of this child? So they will be asking about development quotient.
Uh, Sir, like we need to calculate the developmental, in each domain, we need to calculate the developmental quotient, sir. So this would be the last attained milestone which the baby has attained at whatever age it is by the expected age into 100.
Okay. So here for the gross motor, what is the development quotient here? So it's
Uh,
4 by
Neck holding, yes, sir.
it's 4 months by the chronological age of
4 by
10
10.
months
Yes,
multiply
sir.
by 100.
40%.
So you have to finally say the development quotient for each domain. So like that. Okay.
Yes,
So
sir.
fine motor.
Bidextrous reach is around 6 months, sir.
Hmm. So for
Uh,
in fine motor, we have to say that initially the palms remained open, opening of the hands. When did that happen? Palms remain open. But you said
at
that
two
the
months, sir.
baby is keeping the hands clenched.
Yes, sir.
Then how did the bidextrous reach happen? Bidextrous grasp when it is keeping everything closed. Bidextrous is
Yes, sir.
holding things with both the hands.
Yes, sir.
So that's where the reliability of the mother comes. You
Yes,
cannot
sir.
have both. I think we can do one thing, Prashanta. So
Yes, sir.
you can mute your button while I am talking. I think that's
Yes,
the
sir.
echo is coming. Ha ha ha.
I'll mute it, sir.
Hello, am I audible? Uh, so I think here there is a discrepancy. The mother is saying that the hands are clenched, okay, closed fist. So in closed fist, the hands are not open at all, but the bidextrous reach is present. They are saying, okay. So that is a query. Okay, Prashant. So now you tell me how the development quotient for fine motor.
Sir, it should be 6 by 10 into 100, sir. So around 60%.
Okay, okay. 6 by 10 into 100, so 60%. Similarly, social, just a social smile only we got attained at 2 months of age. So development quotient for social,
20 percentage, sir.
20 percentage. Okay. So language, 3
Language
months.
is around 3 months, sir. So it vocalizes at 2 months. So it should be 30 percentage.
Okay. Okay. So fairly, do you feel all the domains are equally affected or anything predominantly affected here?
The social and the language milestones are predominantly affected, sir.
Okay, okay. Uh, but almost same, almost it's around the same, around 2 months, 3 months, and 4 months. So neck holding is around 4 months. I would say rather it as a global developmental delay. Okay, what do you infer, Prashant? Do you think it's a global developmental delay, or is there a developmental dissociation? What is developmental dissociation?
Sir, when the other milestones have been attained before the milestone that it has to attain, sir,
So one domain is more affected than
than
the
the other
other
domains.
domains. So that is
It,
developmental
it is a
dissociation.
global developmental delay because more than 1 to 2 milestone domains have been affected.
Okay, so that's how you have to elaborate. You have to elaborate in detail the developmental milestone in each domain, calculate the development quotient, and try to figure out whether you are dealing with a global developmental delay or a developmental dissociation. Okay, so in cerebral palsy, how will be the pattern, Prashant? In cerebral palsy?
Sir, it can be a global developmental delay, sir.
Okay, or if at all you want dissociation, how it should be?
The motor domain is grossly affected, and the other domains are better than
Ha,
the
ha,
motor
ha.
domain.
So if you are able to elicit this history in developmental history, I think it's fine. You have understood the whole crux of it. So there should be a developmental dissociation towards motor development in cerebral palsy, or a global developmental delay should be there. Try to divide into 4 domains. Try to find out what is the last milestone which has been attained. Try to calculate the development quotient. Then one more thing we should understand is the concept of developmental regression. Okay, we don't have regression in cerebral palsy. So what is regression, Prashant?
Sir, regression can occur in conditions like Rett syndrome, sir, where initially
Mm.
the milestones have been attained at age appropriate durations, but at a later point of time, due to regression of the neuronal architecture or due to a regression in the functional capacity of the brain, there is a paucity of developmental that occurs and hence a staggered development, sir.
Okay, so that's what a regression where you lose the milestones, whatever you have attained. So that is not the characteristic feature of cerebral palsy. If you have something like that, some usually for an undergraduate they will not give you cases like that. But if it is staring before you, such a history, you have to come up and openly say that, sir, these features are not fitting into cerebral palsy. Sir, the child had an episode of seizures, and followed by that whatever the child attained the milestones, the child is starting to lose. So I don't think that this is a case of cerebral palsy. Probably, as you say, if it's a girl child, it's Rett syndrome, or it could be part of some
Asperger's.
neurodegenerative disorders. Okay, and one important milestone which I would like to say is the pincer grasp. Okay, the fine motor in cerebral palsy, everything the baby might have attained, the bidextrous, unidextrous, but once it comes to the pincer grasp, it's not so easy for a CP child to attain the pincer grasp. So try to answer. But here, the age is still very early. It's the baby is hardly 10, 11 months. Usually, the baby is 2 years, 3 years. Then you will be able to interpret the delay. You can what to say? You can understand the delay very well. So now it's like for through 3 months hardly, then the baby is only 9, 10 months. Delay is there, but the extent of delay as the years progress, you will be able to say. And finding out the motor delay in this will clinch your diagnosis towards the cerebral palsy. And as you say very nicely, in developmental history, try to add the vision and hearing. Okay, you have written very nicely, because they are the windows of development. So a child who is having poor language, you say that language is very much affected. So if the hearing is bad, definitely the language is not going to be good. So these are the windows of development: vision and hearing. So you have to do that. Okay, I think we can go back. This is the presenting complaint. So you have stiffness followed by delay in the development. We have bisected it. We have found out that it is a global developmental delay without any regression. Okay, you can move on. Okay, you can go back. Huh.
Sir, shall I continue? Complications: no history of any abnormal movements, no history of any vomiting or feeding difficulties or poor weight gain, no history of any deformities or bed sores, no history of recurrent respiratory tract infections or constipation, history of seizures in the neonatal period for which the child was on anti-epileptic drugs, history of sleep disturbances or behavioral disturbances.
Okay. So, Raghu, next. Huh. So, this you have attempted to find out the complications associated with cerebral palsy. So, we started with the delay. We started to bisect whether it is a global or a motor developmental delay. And after that, we are trying to find out the associated complications with cerebral palsy. So, these are the associated complications. They can have feeding difficulties, they can have constipation, behavioral disturbances, sleep disturbances. So fine, feeding difficulties is very, very common in this history of feeding difficulties and poor weight gain. Good, good. You have done well. Okay, we can move on to the next. So associated complications. Okay, next.
Higher function: child interacts with the mother, sleeps well throughout the night. Cranial nerves: mother gives history that the child is recognizing and following light. Second nerve: no history of abnormal eye position. Third, fourth, and sixth nerve. No history of defective suckling. Fifth nerve. Next slide.
Okay, so I think you can go to the next slide.
No history of
Continue.
deviation of the angle of mouth, drooling of saliva, seventh nerve, or facial asymmetry. Mother gives history that the child is not turning to sounds, eighth nerve. No history of regurgitation, nasal while feeding, and with positioning of secretions, ninth nerve. No history of abnormal movements of the tongue. Motor: child is moving all the four limbs. Sensory: child is able to perceive sensation while bathing. Autonomic: bowel and bladder control not attained.
Okay, good, good. So you have made an attempt to do a brief CNS examination based on history itself. So which is a good thing. So I think you can follow the same pattern for each nerve, cranial nerve. You have asked the questions related to that. I think one point I can add is following light. Whether the baby is following light for optic nerve, you have asked. One more you can ask is the reaching out for objects. So reaching out for objects, you need a good vision. What else you need in addition to a good vision?
The milestone has to be attained, sir.
Okay,
If
so
the
you
milestones
need
have not been attained, the baby will not be able to perform. So that should not be misinterpreted.
and we need a good coordination also. We need a good coordination to reach. So it's an attempt to
Cerebellar
assess
involvement.
the optic nerve as well as cerebellar function. So reaching out for objects. Okay. Okay. Prashant, continue. Next slide. Okay. And one important significant finding in the cranial nerve you have found is the baby is not turning to sounds. So what is the implication? The baby is not turning to sounds.
Uh, Sir, it could be that the eighth nerve is affected and hence the baby is not responding to sounds. Maybe some banging sound or maybe the sound of a plate falling down. These are some common instances when the baby will respond to. And hence, again, the baby will not be able to vocalize or coo, maybe even because of this.
And if we don't address this, the language domain is going to get
Will be
affected. So
grossly impaired.
that is the main implication behind it. Okay. Okay. Keep continuing.
Antenatal history: first trimester, the age at marriage of the parents is at 23 years. A spontaneous conception after 1 month, with no history of abortion or miscarriages, and no history of infertility treatment. Registered and immunized with 2 doses of TD vaccine. Took iron and folic acid tablets with no history of fever with rash or lymphadenopathy. No history of pregnancy induced hypertension or gestational diabetes mellitus or anemia or blood transfusion given by the mother. No history of drug intake or radiation exposure or seizure disorders.
Okay. Good. Good. Mm, next slide. Raghu. So here is the crux. So you have found out that motor system or there is a developmental delay is there. You have tried to identify the associated problems with this. Okay. Then in the history, most important is in cerebral palsy is an insult to the growing brain. So now you have to find out the insult. Definitely the examiner will be behind after you to where is the insult. So it could be, we should understand that cerebral palsy is a umbrella diagnosis. It's an umbrella term. The causes might be many. The causes starts from antenatal, perinatal, postnatal. So all the questions which you have asked is trying to address that etiology. Okay. So what all you feel, Prashant, the commonest causes?
The commonest cause is actually antenatal insult rather than birth asphyxia, as is commonly thought, sir. So
Okay.
the first thing that should strike would be an antenatal insult. The
Okay.
second thing being birth asphyxia, and it can also be causes like infections, such as with fever with rash, implying that, say, rubella, where that could be a microcephaly, and hence, or maybe even toxoplasmosis. So these are certain intrauterine infections that can be suspected. Then there could also be some ischemic condition that could have led to maybe hypoxia, sir. So
Okay.
or maybe a genetic syndrome as well, syndromic associations. So
Okay.
these could be causes.
So the causes are many. So you tell any adverse event during pregnancy that can cause cerebral palsy. Okay. Can PAH cause cerebral palsy? Yes, it can cause. Can GDM cause cerebral palsy? Yes, it can cause. So can a mother not taking folate can cause cerebral palsy? Yes, it can cause. Can any drug intake cause cerebral palsy? Yes, it can cause. So it's like, it's any adverse event to the pregnancy is a known risk factor for cerebral palsy. The list is many, but in Nelson, what are the important things they have given is infections. So infections in the mother, either it is a later like chorioamnionitis, foul smelling liquor, so those sort of infections, or the torch infection. So all these are prone for cerebral palsy. One more common which they have found out is multiple pregnancy. So you have a twin gestation. The more the number of gestation, the higher the chance of so basically the environment becomes adverse for the baby. So there is a chance of insult. And now because of the care is improving, more the care is improving for all the deliveries, your pediatrician is there. So perinatal asphyxia is going to be on the downside only. Always you are there with a bag and mask to give the resuscitation. You have the NRP protocol. So it's coming down. But what is coming up is the prematurity. So a lot of babies are born premature. So they are prone for you. So recently my friend was talking about saving a 250 grams. I can't even believe. So 250-gram baby is surviving to 2.5 kg. So prematurity, and because of that you can have cerebral palsy. And one more risk if you see is the boy baby compared to girls, boy babies with IUGR. So our case is what? Our case is a boy baby, no?
It's a
So
male, sir.
it fits with that, no? So boy babies are prone. They don't cope up with the adverse event, I feel. So boy babies with IUGR. Let's see the weight when we go back. Okay. Okay. Keep continuing. So you have tried to attempt to find out all the adverse events during the first trimester, antenatal, perinatal, and postnatal. Keep going. Okay.
Natal history: full-term normal vaginal delivery in Ponneri Government Hospital with a birth weight of 2.2 kilograms. Baby did not cry immediately after birth. Bag and mask ventilation was initiated and was admitted in the neonatal intensive care unit. Labor was a prolonged labor with poor maternal effort and delivered with forceps.
Okay. Okay. So see, I said no. So IUGR. So what do you say about birth weight? So 2.2 kg. Do you feel it's normal, or we call that as a low birth weight?
It is low birth weight, sir. Anything less than 2.5 kilograms for a term baby is
Yeah.
considered
So it's a
low birth
low
weight.
birth. So it's a low birth weight, and I feel that you should have a sequence in presenting the natal history also. So start with the labor, say that it is prolonged labor, then you have used forceps, and then the baby didn't cry. So have a sequence. So always try to put it up in a story format. So the baby didn't cry, and then the baby was admitted in NICU. And once such a stormy event has happened, you have used forceps, and here you are saying a normal vaginal delivery. Can you term it in a better way? Mm.
Assisted vaginal delivery.
Assisted vaginal delivery, because we have used forceps, and so it's not a normal vaginal delivery. So I think you have pinpointed the problem, no? So in it still, even though birth asphyxia is not the problem in developing countries, in India still I think birth asphyxia plays an important part in cerebral palsy. So that is evident in this case. Okay, so the event you got the adverse event. Okay, and sometimes mother will not know very well what happened during delivery, whether baby cried or not, whether they used forceps or not, what was the abgar, they might not know. So what are the clues to say that everything was not normal? So what history, two things you will ask in history to say that?
Uh, so the patient might have supporting records
No,
to
only the history you ask the mother these two things.
the duration of labor, sir.
Duration of labor, still the baby might be normal even after labor.
Um,
Baby was at a real problem.
Whether the baby
Baby,
was with the mother or
hmm,
separated after birth
okay, very
for a
good.
considerable period
So
of time.
kept in NICU. So if the baby is kept in NICU for 1 week, it's not a normal phenomenon, no, it's abnormal.
Yes, sir.
So whether the baby was kept in NICU, mother will know that. Mother may not know about the resuscitation or not. Kept in NICU for 1 week, so that is not normal for the thing. So kept in NICU. Then one more is the feeding. When was the feeding initiated? So mother might say the doctor said baby didn't cry and all those things, and you started feeding within 6 hours. Then I think it might not be a big issue. So when was the feeding started? Whether the baby was kept in NICU or not. So okay, continue.
History of neonatal seizures at 7 hours of life. Ventilated for 1 week in the neonatal intensive care unit, for which the child was started on anti-epileptic drugs. Nose tube feeds at the 15th day. Child had 5 episodes of seizures during the stay in the hospital and was started on anti-epileptic drug. Imaging was done and was said to be abnormal and discharged. No history of any difficulty in sucking. No history of neonatal jaundice or cyanosis or a birth injury.
Okay, good. So, Prashant, what do you feel that you have said that seizures on day one? What does it suggest? Seizures in day one.
So seizures in day one is definitely pathological. So in this case, it might be precipitated by a hypoxic event, maybe hypoxic ischemic encephalopathy. So those could have precipitated the seizures, and the seizures might have worsened the development of the brain, and it worsened the hypoxia cyclically.
Okay.
So
So day one seizure, especially when there is a background history of prolonged labor and giving bag and mask. So that is highly suggestive of hypoxic ischemic encephalopathy. You have Sarnath staging, actually, stage 1, stage 2,
yes,
stage
sir.
3. In that stage 2, you get seizures on day 1. So this should be considered as HIE stage 2. What are the other factors which may cause seizures, which can cause cerebral palsy on day one seizures?
Um, Sir, neuronal ill developmental of the brain, sir.
Okay.
Uh, then
Any metabolic, of metabolic cause?
the
Very common. Hmm?
storage
Blood
disorders, sir.
No, don't think very heavy.
Hypoglycemia.
It's a common
Hypoglycemia, sir.
hypoglycemia. Hypoglycemia. So the baby kept in NICU, not feeding not started. So hypoglycemia can cause seizures, and this hypoglycemia definitely will affect the development of the brain. So hypoglycemic seizures on day one, or birth asphyxia on day one, and sometimes you can also have sepsis as a component causing seizures, but not so early in day one. So these are the factors which can affect. So seizures on day one, so birth asphyxia HI stage 2. Okay, good. Go on. Go on. And you have also tried to elicit history of jaundice, which is another important cause of cerebral palsy, right? So
Yes, sir.
Kernicterus and cerebral.
Bilirubin-induced neurological damage.
You have tried to elicit that. Good, good. Continue. So this one we talked about the developmental history. Okay. Hmm.
Diet
Diet.
history, exclusive breastfeeding adequately given till 6 months of age. After that, complementary feeds were started, such as mashed food, Italy, etc. And a family history with no history of similar illness or seizure disorders in the family.
Okay. Hmm. Okay, so I think one important complication or problem with cerebral palsy is the feeding difficulties. So they often do get the feeding difficulties. You get the bulbar palsy in quadriparesis, pseudobulbar palsy. So they have this swallowing problems. They have this incoordination problems. So these things you have to address, see whether the feeding has been adequate or not. So feeding difficulties is a very important. Even in the dyskinetic CP also, you have the tongue often protruding and the baby spitting out whatever the food you give. And they also do get often the micro aspirations. So they do get the aspirations and recurrent respiratory tract infection. So I think not just the 24-hour recall, you have to ask some questions related to the feeding difficulties. So whether they are taking a lot of time in feeding it, whether the baby is spitting out all the food, whether the baby is coughing during the it suggests the aspiration, so that you can address. And if there is a failure to thrive, which we will go back, if there is a malnutrition, and definitely we need to address how much the child is intaking. So a 24-hour recall we have to take, so how much calories and how much is expected for this age. So you have to document this in this condition. So I feel in CP, the presenting complaints you have concentrated, the developmental history is very important, and if you have a failure to thrive, you have to elaborate much more detail in the diet history. Okay. And family history, good. If there is a recurring phenomenon happening, then the genetic component is there, so you have to further evaluate. It's not just a single insult, so there could be a genetic component involved behind this insult, so you have to further evaluate such cases. Okay. Okay, continue.
Immunization history, immunized up to age according to the National Immunization Schedule. Last vaccine at 14 weeks of age. Uh, Pentavalent, OPV, Rota, and IPV. Optional vaccine not given. Socioeconomic history, lower middle class according to the modified Kupaswamy scale. Treatment history, physiotherapy for the past.
Okay, continue, Raghu. Continue the slide. Okay, so we said already that there is a micro aspiration going on. So they are prone for the recurrent respiratory tract infection. So it's better to advise pneumococcal vaccine.
Influenza.
Influenza vaccine, good. So pneumococcal and influenza vaccine, if affordability is good. Okay, because they are prone for infection, they have a failure to thrive, their immunity is less, so it's better to cover up those vaccines, but it depends on the affordability. You have to look into the affordability. Okay, good. And treatment history, if there is a seizure history, then I think you should be in detail about what the medications the child is taking. So those things you have to take in the treatment history. Okay, continue. Summary.
Summary, 10-month-old male child, the firstborn child of non-consanguineous marriage, term with a neonatal birth weight of 2.3 kilograms, has a history of delay in the milestones and stiffening of all four limbs, with abnormal or even full perinatal period, with neonatal seizures on day 1 and NICU admission of 10 days. Probably a case of spastic quadriparesis due to hypoxic ischemic encephalopathy as a sequelae with hearing impairment.
Okay, okay. I think you have well written the summary. Just the normal birth weight, you understood that 2.2 is low birth weight, so that you have to do. And regarding the delay in milestones, it's better to write a further interpretation whether it is a global developmental delay. Okay, so history of delay in milestones, you have interpreted that it is a global developmental delay, so tell that in the summary, global developmental delay, or if there is a dissociation in the development, so that you have to say. And also say that it's a static and there is no regression in the development. And try to say the associated complaints here, positive associated complaints. So you have some sleep disturbances, feeding difficulties, so those things you can say in the associated complaints. And etiology, you have very well said that there is a significant etiology, and you have very well highlighted the hearing impairment also. Okay, continue, Pa.
General examination. Child is alert, awake, quiet in the mother's lap. Presence of stridor. Posture, upper limb, adducted at the shoulder joint, flexed at the elbow, slightly flexed at the wrist. Flexion of the finger with presence of cortical thumb. Lower limb, extended at the hip joint and adducted. Extended at the knee joint with plantar flexion in the ankle joint. Scissoring of the lower limb positive.
Okay, okay, good. So, Prashant, so what do you uh, behavioral disturbances? So, general examination is the place where you can talk about the behavioral disturbances. Usually, the babies might be irritable, so they have this cerebral problem. No, so the babies can be irritable. Some behavioral disturbances can be there. Okay, and what is this posture as a whole? Do you understand, Prashant? So you have said
Uh,
the it's flexed and flexion at the wrist and extension at the knee joint. So what does this suggest?
Generally, sir, the normal posture of the baby is with a flexion in the upper limb and extension of the lower limb.
Okay, so
So, so
why
the
is it?
baby is trying to take up. Um, sir, to attain balance.
Okay, so this is because of the one of the feature of spasticity. What is spasticity? Spasticity and rigidity. What is the difference? Spasticity
Uh,
and rigidity.
Sir, it depends on passive stretching, sir. Like with rigidity, with passive stretching, the tone differs, while in spasticity, the tone is constant and it is an increased tone that is observed in both.
Okay, okay. So increased tone is there, but spasticity is differential increase in the tone. Okay, so you will have the anti-gravity muscles, which is more in the tone, and because of the in upper limbs, which is your anti-gravity muscles?
Uh, Sir, the biceps and triceps.
Not triceps, no. Either one only will be there, no. So
Biceps.
the biceps is your anti-gravity muscle, and because of that only you will have flexion at the elbow. Okay, so the anti-gravity muscles are increased in the tone, so that's why you have flexion at the elbow, and so that's why you are having this posture. Similarly, in lower limb, why is it extended? Because your anti-gravity muscle is what? Your quadriceps femoris. Your
Quadriceps.
quadriceps
Yes.
femoris is your anti-gravity muscle, which are the extensors, and that's why your leg is extended, and even your ankle is plantar flexion. Okay, because the gastrocnemius is more powerful, no. So that's why you have the plantar flexion and tiptoeing is there. Tiptoeing is there, and scissoring means because of the adductor muscles are increased in the tone, and that's why you have scissoring. Okay, so this is a feature of spasticity where there is a differential increase in the tone of the anti-gravity muscles. And what is this cortical thumb?
Sir, like the thumb is always brought inside the palm and there is a clasp.
That is also a feature of cerebral palsy, no? An early
Yes, sir.
marker. We can say that early marker. So we said a clenched fist and cortical thumb. These are all early markers of cerebral palsy. Okay, continue. Continue.
Head to foot examination. Microcephaly with a head circumference of 36 centimeters, which is less than the third percentile. Anterior fontanelle open, 2 cross 1 centimeters. No overriding of suture with a normal hair and no loss of occiput hair. Eyes, no cataract, no squint, no nystagmus, no ptosis, not fixed and following light. Normal ears with no startled response to sounds.
Okay, okay. So most important to start with in the uh, Anthropometry section is head circumference. No, so microcephaly is almost universally should be present in cerebral palsy. Okay, so there is an insult to the brain, developing brain, so the brain doesn't grow. So you will have microcephaly. So you might be asked about what is the definition of microcephaly, Prashant. What is
Sir, it is 2 standard deviations lesser than the median for that age, sir.
No, that's what very commonly they ask this question. So macrocephaly is more than 2 standard
Sorry,
deviation.
this is -3
Microcephaly
standard
is
and that is 2, sir.
so
Macro is 2
microcephaly is
and -3 is micro.
micro is less than 3 standard deviation. Definitely they will ask you this. Okay, in cerebral palsy, less than 3 standard deviation. Centile, it will come as 1 centile. Then, if at all you want to put it in centile, 1 centile. 3 centile is 2 standard deviation. 1 centile will be 3 standard deviation. Okay, so
Yes, sir.
microcephaly is a universal feature of cerebral palsy, and you have said about this not fixing to light, and is he following the light or not following the light?
The eyes are not fixed, but he's following light, sir.
He's
Not
following.
fixed, separate and following light.
So he's following light. Okay.
Yes, sir.
So he's not having the startle response to the sound, which we had that issue. So the baby is not turning to sound. So now no startle reflex, and fixing, the baby is not fixing to light, but following light. Okay. So some issue is there with the eyes also. Okay. Continue.
Skin, no neurocutaneous markers, bed sores, or signs of vitamin deficiency. Intermittent opisthotonus positive. Spine normal with no pallor. Presence of cortical thumb with a normal external genitalia.
Okay. So universally, any CNS case, you are expected to say that there are no neurocutaneous markers. So just like for chronic liver disease, you say no evidence of any chronic liver disease features like spider nevi, etc. No flapping tremor. So like that in CNS, if you have a CNS case, you should always say that no evidence of any neurocutaneous markers like neurofibromas. Okay, the Chagrin patch, Chagrin patch, okay, and any pediatrics case, all pediatrics case, you will get points when you say that no evidence of any vitamin deficiency, especially in this child where nutrition may not be so good. No, so head to foot you look for bite out spot, chelosis, glossitis, rickets. Okay, so those vitamin deficiencies you have pointed out nicely, so that you have to see, especially in this child where nutrition might be a problem, and they have a very poor oral hygiene. So always look for orally the dental caries and all those things. Okay, continue.
Vital signs: heart rate of 110 per minute, regular in rhythm. Respiratory rate of 28 per minute. The blood pressure is 80/60 mmHg in the right upper limb, and the saturation at 99% in room air. Temperature afebrile. Anthropometry, weight of 6.5 kilograms with a length of 60 meters. Head circumference currently at 45 centimeters, which is again less than the third percentile.
Okay. So here they will expect you to I wanted to say this. We should not be a tailor who is only giving the measurements. Okay, you just take the tape and do the measurements. You have to give your interpretation. So try to apply with the WHO growth charts and say what does it mean, whether you are dealing with malnutrition or not. Okay, so especially we need the weight for height. We need to look into the weight for height, see whether it is less than 3 standard deviation, which fits for SAM or not.
Severe acute malnutrition. Yes.
It falls under does it fall, Prashant?
Yes, sir.
Okay. So you have seen that you just mentioned that your interpretation findings. Okay. Similarly, I always say that we in the diet history, many say that child takes 2 idlis, 4 dosa, chapati, rice, and so we should not be a hotel server to tell the menu. Okay, we have to give our interpretation. How much calorie the child is taking, and how
Calorie
much
deficit.
how much calorie deficit. Otherwise, it will mostly irritate the examiner if we just say he eats 2 chapati and vada. Okay, so just for the, and always compare with WHO growth chart if less than 5 years, and more than 5 years use the IAP
IAP growth chart.
Okay, okay, continue.
CNS examination, higher function, awake, does not respond to call, not recognizing the mother. The first cranial nerve could not be tested because the child was under 2 years of age. Second cranial nerve, not fixing and follows light. Menas reflex absent with a bilateral pupil equally reacting to light. The fundus was not tested. The third, fourth, and sixth nerves, no ptosis or nystagmus or squint. Child not following light. Fifth, no wasting of temporal muscles. Corneal and conjunctival reflex are positive. Jaw jerk is again positive. Seventh nerve, no facial asymmetry while crying, no deviation of the angle of mouth, nasolabial fold seen equally in both the sides, with no drooling of saliva. Eighth nerve, not turning to sounds. Ninth and tenth nerve, uvula in the midline with pooling of secretions. 11th nerve, turns head to both sides. 12th nerve, the tongue is in midline with no fasciculations.
Okay, okay. So what's your positive findings here?
Sir, that the eighth nerve is affected most probably because the child is not responding to sounds. And with
Okay.
respect to the second cranial nerve, vision might be affected because the pupil, because the child is not able to fix and follow light very clearly.
And menace reflex is absent. So you
Absent.
take your hands near the eyes, and the baby is not blinking the eyes. But what does this mean? The absent menace reflex not able to fix, but pupillary reflex is normal. So what is your interpretation about that?
Sir, that the pupillary reflexes are mediated by the third and fifth nerve, sir.
Okay.
So we can say
Mediated by
that.
third. No, the afferent is optic only. No, pupillary reflex.
So, sorry, sir. Yes, sir.
So how come one side you are seeing query vision, and the other side the pupillary reflex is present? Present.
Um,
So that's the phenomenon which you see in the definition when you look into the definition of cortical blindness. No, cortical blindness, where the
yes, sir.
cortex is the problem. So your pupillary reflex will be intact, but the baby will have a poor vision. So here you are, since the cerebral palsy, cerebrum is at fault. So what you're dealing is with cortical blindness. Okay, and
Yes, sir.
hearing is also a problem, and maybe others are fine. Jaw jerk will be exaggerated, suggesting pseudobulbar palsy. Maybe they might hesitate when you talk about corneal reflex. Okay, so we need to be careful not to injure. So just conjunctival reflex is fine. Okay, and otherwise it's fine. Okay, good. Continue.
Spinomotor system. The pull to sit head lag has not been seen. Ventral suspension. Head lies at the plane of the body. With vertical suspension, there is the scissoring of the limbs. The bulk is equal in both the upper and lower limbs with no muscle wasting. The tone, there is an increased tone with spasticity in all the four limbs, with a power of 3 on 5 in all the four limbs, both the upper and lower on both sides.
Okay, good. So I think this 4 lines initially you have written is very good. So it's not just about examining the tone, power, and DTR. Try these 3 maneuvers. One is pull to sit. While you do the pull to sit, see whether there is any head lag. Then another is the ventral suspension. Try to hold the baby on your hand,
Abdomen.
ventral suspension. See whether the head is floppy or just lying at the plane of the body. And vertical suspension, you know whether the baby is floppy or scissoring of the limbs is seen. So here scissoring, we obviously know that scissoring of the limbs is seen. So this is a very good 3 points which you have mentioned. And the question again we discussed earlier is about spasticity versus rigidity. So you have said that here spastic. So all 4 limbs spastic. So one we said is anti-gravity muscles differential involvement. So how will you clinically differentiate spasticity versus rigidity, Prashant?
So with passive stretching of the limbs, if there is an increase, then we can account it for rigidity, sir.
Okay. So
Uh,
rigidity. So rigidity and spasticity, as you say, anti-gravity muscles. So one side resistance will be more, the other side there will be not much resistance while doing the passive movement. Okay. So for example, in biceps, in the limbs, while extending, you will have a lot of difficulty in extending, but it will be easier to flex. So
yes, sir.
that's the thing. But in rigidity, both flexion and extension equally will be difficult. So that point you should understand. Then what is this clasp knife rigidity? Clasp
Um,
knife rigidity. Clasp knife spasticity.
Not sure to define it, sir.
Okay. So clasp knife, when you open a clasp knife, no? So initially you will have that difficulty in opening, and suddenly there will be a giveaway. So that's seen in spasticity. So that's why we call it as initially while extending from the flexion position, it will be tough, and suddenly there will be a giveaway. And this giveaway will be easily appreciated when you do it faster. And that's why spasticity is velocity dependent. We call that as
Yes,
velocity dependent, and rigidity is not velocity dependent. Okay, so they might ask you these things. So what is spasticity and rigidity? There is a differential increase in the tone between anti-gravity muscles. Okay, and there is a clasp knife spasticity will be there. Initially there will be a resistance followed by the giveaway, and it is velocity dependent. Okay, why not 4/5? Why are you saying 3/5 power here?
Sir, the power is graded by the MRC grading, sir. So 5/5 is a normal power, and 4/5 indicates that there is some resistance, but maybe but not resistance to the examiner's examination, but not
Okay,
maybe
so why
considerable.
were we
3 on
not
5
able to?
is
Why didn't we give 4/5 here?
sir, because in 3/5 the when the effect of gravity is eliminated, then we experience that the power of the muscles is felt, sir. So in this case, it was when the gravity was eliminated, the power could be felt.
No. Then gravity is eliminated, it becomes 2/5. Okay. So here it is 3/5 because the baby is able to move the limbs against the gravity. So that's why it is 3/5. Why not 4/5 now? It's very difficult to assess after giving some resistance because the baby is not able to understand. No. So we are not able to assess 4/5. That's all. It doesn't mean that the baby is not having 4/5.
Okay,
Understand,
sir.
Prashant? So
Yes,
we
sir.
are not able to assess 4/5 because the baby is not understanding, the baby is not cooperating. So if if the baby is lifting the limbs above the ground against the gravity, so that's why 3/5 we are giving. Okay, so that's why it's written best observed. So you observed, best observed. It doesn't mean that it is the power. So the baby can have definitely 4/5, just what you can observe. Okay,
Yes, sir.
continue. And one more is about the contractures and spasticity. You should always make sure that there are no contractures, because if contractures, you have to intervene. So what is the difference now? Uh, However, the tone is increased at one point of time, you should be able to overcome that resistance. That only will happen in spasticity. But in contracture, since the fibrosis and it has become fixed, so you cannot overcome that position. Okay, however force you apply, you are not able to move beyond that, which means that you are going towards contractures. Okay, continue.
Reflexes, deep tendon reflexes on the right and on the left side, uh, both the upper and the lower limbs. There was a brisk reflex noted with no ankle clonus. The superficial reflexes were positive both on the right and on the left side, with the corneal, conjunctival, and the abdominal reflexes noted. Bilateral plantar extensor and a palatine pharyngeal and cremasteric reflex were noted.
Okay, so what is the what do you understand by this? Brisk and exaggerated. How will you differentiate brisk and exaggerated?
Sir, an exaggerated reflex could point to a clonus, sir.
Clonus is there, it becomes exaggerated. Okay. And what is your final interpretation of all these findings? Spasticity is there, brisk reflexes are there, and your plantar is extensor. Okay, so what do you understand by all this?
Sir, if the Babinski reflex is positive, we can think of pyramidal tract involvement.
Okay, so everything, not just Babinski.
Yes,
Your
sir. Reflexes in general.
spasticity, brisk tendon reflexes, Babinski positive, all these three suggest that the pyramidal tract is involved. Okay, corticospinal tract is involved. Okay, continue.
Primitive reflexes, the Moro reflex was absent. Asymmetric tonic neck reflex was present. No abnormal startle. Palmar grasp was positive and a plantar grasp was positive. Sucking positive. Sensory. The child is able to perceive pain sensation. Autonomic system could not be assessed. Cerebellar system, no nystagmus, no head nodding. Other signs could not be elicited. No abnormal involuntary movements or meningeal signs noted. The spine and cranium was normal.
Okay. So I think you need to have a separate partition. No abnormal involuntary movements doesn't fit with cerebellar system. Similarly, no meningeal signs and spine and cranium are normal. Okay, so that one part. And regarding this primitive reflexes, what is your interpretation? So something is absent, something is present. So what do you, for an 11-month-old child, for a 10-month-old child, what should have not been present actually?
So the asymmetric tonic neck reflex should have been absent here.
Okay, then only what will come? Asymmetric tonic reflex when it gets absent.
Symmetric tonic, sir.
No. Asymmetric disappears, tonic neck reflex disappears. Then only this milestone will come. What is that milestone? Rollover. Okay. So
At
the
6
baby
months.
rollover.
Yes, sir.
Rollover. So the baby will roll over only
Yes,
if asymmetric tonic will be absent. So that should be absent. Moro's reflex usually gets absent by how much time?
3 to 4 months, sir.
4 months. Similarly, palmar grasp, plantar grasp should have been absent by now. Okay, so it should be absent by now, but it is present. Okay, so one important feature of cerebral palsy is persistence of primitive reflexes. So primitive reflexes doesn't disappear for the recommended time. Persistence of primitive reflexes. Similarly, one more term is non-appearance of primitive reflexes. So what primitive reflex you expect to appear at this age?
At around 10 months, sir.
What primitive reflexes?
Um,
which are not present at birth should have appeared, but it has not appeared here.
So the parachute reflex.
So not only persistence of primitive reflexes, non-appearance of some primitive reflexes like Landau reflex and parachute reflex. So that also points towards cerebral palsy. Okay, and in cerebellar system, I said no. So you can easily try out this reaching out for objects. See whether there is any intentional tremor while giving objects. See whether there is any past pointing and thing. But the problem here is the vision itself is at stake here. So we don't know whether the vision is good. So it's tough to assess here. Okay. And for any child with CNS, just like neurocutaneous markers, always say whether there is any meningeal signs and spine and cranium is normal. Although you will not be given a pyomeningitis case, but still you have to say that no meningeal signs, spine and cranium normal. For completion sake, you should always see. Okay. Continue, Pa.
Other systems, the cardiovascular system, S1, S2 heard with no murmurs, respiratory system, bilateral air entry positive with no added sounds, abdomen soft with no organomegaly, and mass of equilet. Diagnosis, spastic quadriparesis, possibly cerebral palsy with microcephaly, and vision and hearing impairment or global developmental delay, probably as a sequelae of hypoxic ischemic encephalopathy.
With regards to the here organ system, organomegaly is very important. Okay, organomegaly, a child with resembling cerebral palsy having organomegaly, always think of some storage disorder leading on to neurodegenerative disorder. It's very early to say whether the child will lose milestones or not. So whenever you have a hepatosplenomegaly with developmental delay, keep in mind that it could be a storage disorder. Okay, and try to summarize all the positive findings here before telling the diagnosis, because in exam sometimes they might not ask you the full presentation like this. It takes almost an hour to do the full presentation, no? So they might ask you to summarize the positive examination findings. So if you are asked to say the positive examination findings, what all you will say?
So first, I'll start with the demographic data. It's a case of a 10-month-old male child who's come with complaints of delay in the developmental milestones, along with spasticity in all the four limbs.
Okay.
And then, based on the history, a delay in the developmental milestones have been noted, and
Okay.
impaired vision and language domains have been noted. So, and based on the examination, there has been a defect in the second cranial nerve and the eighth cranial nerve, evidenced by the loss of hearing and inability to fix and follow light.
Okay.
So, apart from that, um, the reflexes were normal.
Reflexes brisk.
Yes, the reflexes were brisk.
Okay.
So, and no other associated comorbidities or complaints.
Okay. Okay. And you have a
With
malnutrition,
a
no?
past history of hypoxic ischemic encephalopathy.
Okay. Okay. And we have a malnutrition there, no? Okay.
Yes, sir.
Okay. So good. So first is the summary, then followed by the diagnosis. While giving the diagnosis, make sure that you start with it's a case of cerebral palsy. So what is the diagnosis? It's a case of cerebral palsy. Then you give the physiological classification, you give the topographical classification, if possible the functional classification, and say the associated complications. So I think you have enumerated all the associated complications here. Okay. Wait. Okay. And try to give the etiology, try to say the development, whether it is global developmental delay, and finally the nutrition. So here we have a SAM. So you have to say the SAM, severe acute malnutrition. So in the physiological, what is the physiological classification of CP? How will you give the physiological classification?
Sir, based on the area involved, sir.
So that is topographical. Physiological will
The limb
be
involved.
physiological is spastic cerebral palsy. Okay.
Yes, sir. Actitoid or
Ataxic,
dyskinetic.
chorioactitoid cerebral palsy or dyskinetic cerebral palsy or mixed type of CP. So that is your physiological. Topographical is whether it is diplegia, hemiplegia, or quadriparesis. And functional classification is, do you know anything about the functional, Prashant?
Sir, it's about the ability of the child to perform his day-to-day activities.
Okay.
Like there are 5 gradings in it, sir.
Okay. You can show the next slide, Raghu. You can tell the 5 grading for level 1.
Level 1, the child is able to carry objects and carry out his day-to-day activities against gravity.
Independently. Okay.
Independently. At level 2, the child is able to perform activities which are not strainful against gravity.
Okay. Need some help or support. So like
Yes,
while climbing
minimal
stairs,
support.
they hold the stairs and walk. Okay.
At level 3, the child is not ambulatory by own and needs the help of maybe crutches or a wheelchair. So wheelchair
We call
dependent.
that as the self-propelling devices. So they themselves move the device, self-propelling assistive devices. Okay. Level 4.
Yes, at level 4, the child is almost wheelchair dependent, such that it's an automated wheelchair.
Automated,
So
motorized. So they need a
motorized.
motorized devices to move on. And level 5?
The level 5, the patient needs a caretaker who can assist the
Okay.
patient in
Good.
moving
Good.
across.
I think for this child, it's a bit too early to give the functional classification. Child is hardly 11 months. But if you get a 5-year-old child or a 6-year, 7-year, I think you have to apply this classification. Okay.
Yes, sir.
So can you go back? Go back. Okay. So the final summary, as we said, I think you have written it detailedly in the same way as a spastic cerebral palsy with spasticity and quadriparesis. Functional classification, I think it's a bit too young to say about that. Associated complications, you have written microcephaly, vision and hearing impairment. Then etiology, you have said, so hypoxic ischemic encephalopathy as the etiology. And development, we have found out it is a global developmental delay. And nutrition, SAM is there, severe acute malnutrition. I think it's fine. So based on your history and examination, finally you have come to this diagnosis. I think the examiner will be pretty happy if you come with this based on the history and examination. Good. And maybe some discussion points. Raghu, go to the next slides. Last slide. We'll wrap up with these discussion points, another 10 minutes. So spastic hemiplegia, I think we all know one side it is there. Most significant is the handedness. I will tell one point which is very characteristic. So in a baby, the one side movements will be less. There will be a paucity of movements on one side, and handedness will start coming in hemiplegia. So hemiplegia, spastic hemiplegia, what is the commonest cause, Prashant, etiology?
So birth asphyxia.
Okay, birth asphyxia. More than that, the stroke, intrauterine stroke, where almost like hemiplegia is because of stroke, no? Just like that in babies also you can get intrauterine stroke where hemiplegia is there. Spastic diplegia, we only the lower limbs will be affected and you have the scissoring. And soft sign will be initially when the baby is sitting, the baby will be sitting fine, head control will be fine, rollover will be fine. But once when it comes to crawling, it will be like the baby is moving with his hands alone. So the legs will be dragging during the crawling because the legs are weak. The legs are having paresis. So you have this commando crawl and scissoring in spastic diplegia. Most important etiology for diplegia, Prashant? They will ask you.
Sir, antenatal insult, maybe, sir.
You should never forget preterm, prematurity.
Yes, sir.
So prematurity, prevent, these three words you should say: prematurity, periventricular leukomalacia, diplegia. Okay, so
Yes, sir.
remember that. And quadriplegia, all four limbs and trunk also involved. So remember that. Important. Sometimes they will make they will what to say drag you. What is double hemiplegia and quadriplegia? So double hemiplegia, only the limbs are involved, the trunk will not be involved. Quadriparesis, both the trunk, limbs, all are involved. Bulbar region also involved. So they will have severely bedridden, swallowing difficulties, microaspiration, lot of complications in quadriplegia. Severe birth asphyxia, you will have this quadriplegia. And your MRI will have in diplegia periventricular leukomalacia. Here you have this encephalomalacia, severe encephalomalacia. So a lot of areas, cystic encephalomalacia will be there. And chorioathetoid, very common, even in birth asphyxia, you get chorioathetoid, but very common will
Neonatal
be your
jaundice.
jaundice. Okay, so jaundice leading on to chorioathetoid, kernicterus. Very common finding in chorioathetoid is your feeding difficulties. They keep on having this involuntary movement of the tongue, resulting in the feeding difficulties. So they will ask questions related to these things, and they will ask you how will you evaluate. So what investigations, Prashant, you want to do?
Sir, initially I would like to do a MRI of the brain, sir.
Okay.
As a radiological investigation.
Okay.
And apart from that, since this patient has a suspected vision and hearing impairment, I'll also do a vision and hearing testing.
Very
And
good.
apart from that, we can also do a electroencephalogram in
Okay.
general,
Okay. Good. So for any associated problem, you start evaluating for that. But basic will be these three. For your case, basic will be three: MRI, vision, and hearing assessment. And if there is seizure disorder, EEG can always be done. And if you have a idea that it could be a progressive disorder, it looks like a progressive disorder, then you have to evaluate further whether it is a storage disorder, whether it is a IEM, whether it's a karyotype. You have your ABG analysis, okay, so lactate and all those additional tests you start doing if it is a progressive disorder, okay. And remember, they might ask you what are the mimics. There are a lot of mimics which looks exactly like cerebral palsy. They might at least just remember in Nelson it's given spastic diplegia is rarely arginase deficiency. Your urea cycle defect arginase deficiency presents exactly like a spastic diplegia. I looked into the literature, our case, no. So you have stiffness of limbs and hearing and vision abnormality with microcephaly. Everything fits with Krabs disease. Okay, so Krabs disease fits with this. So there are mimics. So as you follow up, you know the baby keeps worsening. So the baby will not be the static. The baby will keep worsening with this. And treatment. What more than the treatment? Is there any preventive options available to reduce this cerebral palsy? They will ask you. Okay, the preventive.
Yes, sir. Effective counseling needs to be undertaken with the parents.
Okay.
We'll have to try to understand the genetic factors involved and about the consanguinity. In this
Okay.
case,
So
it's a
genetic
non-consanguineous
counseling.
marriage.
Genetic
So,
counseling
yes,
important.
sir.
Is there any drug? You know that prematurity is causing now, prematurity is increasing. Any drug which is available to improve the outcome? Less
Sir,
than 32 weeks.
magnesium sulfate is a neuroprotective.
Wonderful, wonderful, wonderful. So if you are saying magnesium sulfate, they are going to give you lot of marks. Okay, so magnesium sulfate is a good neuroprotective, and these antenatal steroids definitely protects the preterm antenatal steroids protects from
Yes, sir.
IVH and thing. And after the baby is born, the baby is not crying. Is there any modality which is going to reduce the complications, reduce the cerebral palsy? Is there any modality which you can?
Uh, Sir, in cases of hypoxic ischemic encephalopathy, now there is a condition where we can induce hypothermia, sir. So
Wonderful, wonderful.
that
So
will prevent brain
therapeutic
damage.
hypothermia, therapeutic hypothermia. So I think more than managing prevention, they might ask you if you are saying that it's good, good, good. So therapeutic hypothermia, magnesium sulfate, antenatal steroids, all those are going to folate. Okay. And this one word they will always ask you, how will you manage? So remember multidisciplinary team.
Multidisciplinary.
So who is your team? Multidisciplinary team.
The first should be the pediatrician, sir. So, along with the pediatrician, we can have an orthopedician, and then maybe to counsel them, we can have a psychiatrist or a geneticist, and maybe a dietitian to explain the aspects of nutrition, and a physiotherapist for rehabilitation.
Mm-hmm. Okay, good, good. So occupational therapist and a physiotherapist. Okay, good. So physiotherapist main aim will be the spasticity. One nice which I learned is speech therapist not only gives the speech therapy, is also concerned with swallowing difficulties, dysphagia. Something you might get in MCQs, no? For dysphagia, whom you should approach is again it's going to be the speech therapist. And for spasticity, is there any physiotherapy you're going to do to reduce the tone? But if it is going to go beyond the limit, you have drugs available to reduce the spasticity. So what are the drugs you know?
Sir, we can give in skeletal muscle relaxants, sir.
Mm-hmm.
So it can be drugs like baclofen, tizanidine.
Okay.
These can be used for muscle relaxation.
Okay.
Or
Okay.
even benzodiazepines can be given for sedation if the child is irritable.
The benzodiazepine is used for tone also. So spasticity,
Yes,
it
sir.
reduces the spasticity also. And baclofen, any route you know of that is better rather than oral?
Sir, intramuscular, sir.
No, it's intrathecal. Intrathecal.
Okay.
Okay. Intrathecal baclofen is good. Benzodiazepine is good for the tone. Botulinum toxin is given intramuscular. So it's given in the area where the tone is high, botulinum toxin. And if the tone is high, any procedure you can do to reduce the tone?
Sir, a tenotomy of the Achilles tendon can be done, sir.
Okay, tenotomy and rhizotomy. In the spinal
Yes, sir.
level, rhizotomy, selective rhizotomy can be done, and tenotomy of the Achilles tendon. And in Nelson, it's a good point we have seen in hemiplegia. Constraint induced movement therapy, where the normal limb is constrained, they put a plaster and they constrain it so that you try to use the hemiplegic limb. So constraint induced movement therapy is a good point I learned actually. So I think it's fine. So you can read a lot in cerebral palsy, a lot of questions will be there, you can always go through back and read that. Okay, fine. Prashant, I'm very happy. It's a wonderful thing. You also learned good things. If you present like this, I think it's going to be a walk in the park. So you will do well. Okay, but the problem is exam should come. Exam should come. That's the next question.
Yes, sir.
Okay.
Yes,
And
sir.
students, I just give another reminder. Just WhatsApp me who are all interested. We are planning around 10 to 15 cases. And since it's a rapid revision, we are trying to cut down on the duration. We want each case to be around half an hour so that it will be easier for you to revise at the end before exams. We want it to be like 6 hours and less so that you revise the whole portion. So that we will do weekly once, three cases, half an hour each. Okay, we have our team of professors. So do message me to this number 9445482710. WhatsApp me. Nominal registration only, we have kept it around rupees 500 only. So see you all for another good session. Any doubts, Raghu? In YouTube you got any doubts?
No, sir. There was no doubt, sir.
Okay, okay. So
Thank you so much.
shall we wrap it?
Prashantano, thank you for joining us, and really a wonderful session. So thank you so much.
Thank you so much, sir, and thank you, Raghu, for the opportunity.
Thank you, Prashant. Thank you, Raghu. Wonderful job you are doing, coordinating all the classes. It's not so easy to do this. So good. So students are benefiting from this initiative. Thank you. Thank you.
Thank you so much, sir. Thank you, sir.
Thank you.
Thanks again, sir.
Thank you, Prashant. Thank you.
Stream ended, sir.